So good afternoon, everyone. Thank you first to the sponsors, L'Oreal, La Roche-Posay, for inviting me. Thank you for Alex for organizing this meeting. What I'll be talking to you today is acne inversa, the hidden scourge. As you all know, acne inversa is another term for hidradenitis, and it's probably one of the most difficult conditions we come across in our consultations. It's frustrating for us, it's frustrating for our patients, and any consultation which involves hidradenitis is so difficult for all involved. So what I thought I'll do today is give you a brief overview of the condition. And one of the most important things I've learned over the years is if you know the way the mechanism of the condition is, if you know the pathology of the condition, you're much more likely to treat the condition appropriately. So I'm going to divide my talk into three parts after a brief introduction. The first is pathogenesis. If we know how the condition evolves, we can treat it more appropriately. We'll then go into clinical features very briefly, and most importantly, we'll focus on the management, because by far that's the most important thing we want to do for our patients. Why do we need to know about this condition? Now, anybody will tell you how hard it is for patients who have hidradenitis. It severely affects the quality of life. It causes embarrassment, self-consciousness, they are in pain, and because of the pain, they are not able to work properly, they are not able to go to social situations, and all this causes anxiety and depression as well. And it's a very variable percentage, 6 to 40%, but I would say that at least 1/3 of the patients who come to our clinics will have some form of mental illness because of their condition. As a brief introduction, it is a condition which affects mainly the folds of the skin. So if you look at it, it's under the armpits, in the inguinal area, in between the gluteal area. And the main pathology is in the follicles, it's in the hair follicles. So it starts off as small inflammatory changes in the hair follicles, and then it evolves into all the pathology that we're going to see. I always like to start off with a little bit of history to find out more about the condition. It was first described by a French anatomist and pathologist called Alfred Velpeau, and that was in 1833. In fact, some authors call it Velpeau's disease. But the person who probably did the most work on it was another French anatomist, and his name is Aristide Benoil. And he worked on it for nearly 20 years, between 1854 and 1865. And he published lots of papers on this condition he called it hidradenosidphlegmosis, and that's a French term. And if you translate that into English, it's called hidradenitis suppurativa. Now, if you look at the breakdown of that term, hydra means sweat, adenitis means inflammation, so it's inflammation of the sweat glands, and suppurativa means there's lots of pus. So the original description by these French gentlemen was that it was an inflammatory disease, mainly around the sweat ducts, which caused a lot of pus. So that's why they called it hidradenitis suppurativa. The prevalence is quite variable. If you look at the papers, it's very, very low in some papers and very, very high in some papers. But on average, I would say it's probably somewhere between 0.5 to 1%, which is almost similar to psoriasis. So it probably is a remarkably common condition, but perhaps the mild condition patients don't actually present to us. They probably manage it themselves. It's mostly young people, young adults, so you can see how terrible it'll be for them if they get this condition because of those symptoms. And it's twice as common in women. And it's also much commoner in African Americans. In fact, it's 3 times more likely to be in the colored races than if you have white skin. I told you that if we know about the pathogenesis, we can treat the condition much more appropriately. And there was a wonderful article in the British Journal of Dermatology about 2 months ago. So most of what I'm going to quote is from that particular article. Let's look at the predisposing factors first. There probably is some form of genetic predisposition. If you look at it, about 30% of those who have hidradenitis have someone in the family who've had it. So it's probably those who have a genetic predisposition who get the condition if the environmental factors are right. What are the environment factors? There are lifestyle issues. These are things which are reversible. If you have an increased body mass index, if you're obese, or if you smoke. And we'll go a little bit into more detail of both these particular risk factors. How does obesity affect hidradenitis? If you look at obesity, there are more skin folds if you have a high body mass index. And when there's skin folds, there's more sweat, there's more maceration, the microbiology of that area changes, there are small areas of friction, and therefore there are erosions there, and that causes inflammation, and that causes some of the changes in hidradenitis. Now, another thing about obesity is, or increased body mass indexes, there seems to be some form of low-grade inflammation associated with it. Now, this is the central obesity, where there's more in the center of your body. And if you have that, which is found in 60% of those who have hidradenitis, you're more likely to have diabetes, high blood pressure, and also high cholesterol. So all these risk factors together seem to play a part in the etiology of hidradenitis. How does smoking cause hidradenitis? Again, there are loads of ways by which it can happen. You're much more likely to get hidradenitis if you have been a smoker or if you're currently a smoker, almost 3 times more likely. And there are various ways by which nicotine in the smoking causes hidradenitis. The first thing is, a hair follicle seems to be the most important way by which hidradenitis occurs. It blocks off the hair follicle. And nicotine induces epidermal hyperplasia. So it's one of the first factors. If you block off the hair follicle, that's what causes all the subsequent effects on the skin. There's also microbial dysbiosis, and I'll be going into this in detail because that's what the British Journal of Dermatology goes into. There's also increased sweat gland secretion of the nicotine. So you sweat more, and when you sweat more, more of the nicotine is getting into the skin. And when that nicotine gets into the skin, that induces inflammation. So that's another risk factor where it causes all these inflammatory changes, and that stimulates the macrophages in the skin. And as I told you, it's an inflammatory disorder, but it's the hair follicle which is the main problem. Sex hormones also seem to play a part, and there are lots of anecdotal evidence for this. For example, you're going to see it mostly in younger people. Once you've had puberty, that's when you start getting hidradenitis. Its severity sometimes decreases in pregnancy. Again, hormonal factors there. And it's unusual in older age groups. So again, as your hormones decline as you go into your 40s, 50s, and 60s, your hidradenitis incidence also comes down. There are some special characteristics of the skin folds which we'll need to look into. I've already told you about the microbial dysbiosis, and that occurs due to various factors. There's a higher temperature when there's folds of skin, there's more sweat, there's more maceration, there's increased moisture, and because of that there's reduced oxygen. So because of this reduced oxygen, the anaerobes become a lot more than the aerobes. Normally in the skin we have only staphylococcus, but here you'll have many more anaerobes, as we'll see soon. Now, this is probably one of the most important slides in the talk, and this is from the article I quoted in the British Journal of Dermatology, and it tells us how the skin microbes change throughout hidradenitis. H is healthy controls, NL is non-lesional skin in hidradenitis, and then as you go to the right, that's when the hidradenitis lesions come on. Now, if you look at the organisms that are involved, in healthy skin, we have mainly staphylococcal epidermidis and corynebacterium, and you have a little bit of cutibacterium as well. In non-lesional skin of hidradenitis, you can see that their incidence is reducing. Now, as you come into hidradenitis itself, as you get the lesions, you can see that they're almost disappearing. So all the aerobes, the normal commensals, are lost as you go into hidradenitis. What happens then in hidradenitis is the anaerobes and other organisms take over. So this organism, Staphylococcus lugdunensis, starts coming up in the acute hidradenitis. This is not the severe hidradenitis, it's the acute small flares. And then as you go much into the chronic phase, much more severe hidradenitis, you get all the anaerobes, Prevotella, Porphyromonas, and Fusobacterium. And this is particular bad in the really severe chronic hidradenitis. So the reason we need to know this is we think things like Staphylococcus and all the gram-positive organisms are what we have to target. We give flucloxacillin. It's incorrect because our organisms are different. It's the anaerobes which are the problem. And that's why we always use combinations in hidradenitis. So if we understand the microbiology of the condition, we're going to treat our patients much more appropriately. So this is just a summary of the organisms which I've mentioned. So for chronic hidradenitis, it's Prevotella and Porphyromonas. For acute mild hidradenitis, I told you there's Staphylococcus, but it's not the aureus, it's Lugdunensis. And then for the chronic severe hidradenitis, it's Fusobacterium. It's all becoming it's anaerobes. Going on to the pathogenesis, this is again one of the most important steps which helps us understand how exactly the condition comes on. The most important step is here. It's the hair follicle. It's getting occluded. And two factors occur here. The one is this epidermal hyperkeratosis, which we've already discussed. So there's blockage of the hair follicle. And there's increased inflammation. And that inflammation may be because of the bacteria collecting, these gram-negative bacteria collecting. Now, we don't know what happens first. Is it the hair follicles being blocked first, or is the bacteria causing the increased inflammation first? We don't know. But what does happen is these get blocked, completely blocked. And when they get blocked, all these things start to cascade. You get inflammatory cells like macrophages, you get all these cytokines, which is what we're targeting later on in our treatment, TNF alpha. That's why we use biologics. Interleukin 1, interferon gamma, macrophages. Now these form a vicious cycle. As these increase more and more inflammatory cells start coming in, and they produce even more cytokines. And that vicious cycle never ceases. It just keeps on coming on and on again. And all the adjacent follicles next to each other starts getting inflamed. That's why they're all together in the hair follicular area, in the axilla and the groin. And that's why all these nodules occur in close proximity. The last step is probably the most important. So I've highlighted this. What happens finally is there's so much of bacteria, inflammation, that the hair follicle is not able to take it anymore. It's blocked there, so it can't come out there, so it ruptures into the skin. And this is what causes those really deep nodules. It's not the superficial pustules you see in Staphylococcus with furuncles. These are deep nodules, which you get only in hidradenitis. And this is probably quite important. These are matrix metalloproteinases. And they're quite important because they cause fragility of the basement membrane, and they cause fragility of the adjacent hair follicles. So deep down, if all these hair follicles are getting weaker, they all start getting connected and they start forming sinuses. So that's typically what you see in hidradenitis. It's not one spot, it's all these spots together and then get connected in the bottom. So all these are connected right at the base. And you'll see that in the clinical features, how it's not one pustule, it's these nodules coming together and forming almost a cribriform area of pustulation. So let's look at it in a brief summary. The first bit is this keratin plug, and it occurs on a background of all these factors: smoking, obesity, mechanical friction, the microorganisms which I've told you, in a genetically susceptible person. As this gets blocked, there is more and more bacterial proliferation. It then becomes more inflamed because of the cytokines provoked by the bacteria. And then finally, all these hair follicles adjacent to each other burst through because of the matrix metalloproteinases, forming these really complex areas of sinuses and cribriform scarring, along with forming a biofilm, which is why it never heals. And that's why when you give these, those who have this condition treatment, You have to give antibiotics for prolonged periods of time. It's not a 7-day course or a 14-day course. You've got to give it for months, because by the time you penetrate really deep into the skin, it takes months to occur. And the pathogenesis involves quite a few other things. The cells which are involved, the number of T cells is actually equal to what you get in psoriasis. And I'm sure you've all seen people with really severe psoriasis getting severe hidradenitis as well. And that's because the T cell infiltrate is very, very similar. The pathogenesis is very similar. B cells may also be involved, and they cause complement production. And that, again, makes it a vicious cycle of inflammatory changes. The pathogenesis, we've already looked at the bacteria. There are abundant bacteria, but they're not the usual skin bacteria. Staphylococcus aureus is not associated. So things like flucloxacillin are not the ideal treatment here. We'll go to the treatment later on. It's mostly opportunistic pathogens, and therefore optimizing the antibiotic treatment is probably quite important. If you can do culture and sensitivities, or you use these other combination treatments for prolonged periods of time, it's going to work much better for our patients. The cytokines, again, very similar to psoriasis, TNF-alpha, interleukin-1b, interleukin-17a. And that's probably the reason why most of the biologics we use for psoriasis actually works for hidradenitis too. There are good reports which suggest that things like secukinumab, which works for interleukin-17, also plays a part in treatment of hidradenitis. Let's go on to the clinical features next. Now, it's a clinical diagnosis. You don't need histology. You don't need to do a biopsy. There are 3 criteria which you need to follow. The first is characteristic lesions. So we look at what these lesions are, and then the predilections for the flexures. Is it in the axilla? Is it in the groin? Is it in the natal cleft? And then a few other areas. And then the third thing is it should keep recurring at that same site, because that's typically what happens in hidradenitis. It doesn't keep spreading. It keeps coming back at the same site and then goes centrifugally. What are the characteristic lesions? They are quite different from furuncles. You get deep-seated inflammatory nodules because it's right at the base of the hair follicle. You get abscesses, sinuses, and bridge scars. Let's look at each one of these in greater detail. So inflammatory nodules, they usually start off as solitary lesions. They are painful, and they are deep-seated. So unlike a furuncle, where you can actually see the pus spot at the top, and if you take the hair follicle off, all the pus comes out. It doesn't happen here. It's so deep that you see only the inflammation. You see only the redness. You don't see the pus. It's very, very insidious as well. It takes a long time. Unlike a bacterial folliculitis of staph, where it comes within a few days, this will take a few weeks, sometimes even months to evolve. And then you get these recurrent episodes. It keeps coming back at the same site. And it's often misdiagnosed as boils or furuncles, but they're different. You don't see that pointing, and boils and furuncles keep spreading. It comes in different parts. This is in the same place. And then, as I said, it's the flexural distribution again. So these are the typical inflammatory nodules. You can see that they don't look like they're on the surface. They're much, much deeper. You don't see any pus there, but actually there's loads of inflammation and pustulation going on in the deeper parts. And if all these join together, you can clearly see how it forms cribriform scarring. Next is the sinus tract, and it's because all these nodules which are next to each other are bursting and communicating with each other. And there's discharge, and that discharge can be serosanguinous, it can be pus, it's usually quite painful, it's malodorous, and you can't clear them because they're all connected at the bottom with numerous pustules together. And it's quite deep. Sometimes if you give an injection in one part of the sinus, all the fluid comes out in the other part because they're all interconnected in the bottom. And this is typically a sinus tract. You can see it's mainly scarred on the surface. So if I was to inject something there, a local anesthetic, all that fluid will start coming out in these because they are connected at the bottom. And you can't really feel them sometimes. They're so deep, you can't even feel them. So these sinus tracts are very, very difficult to treat. So one of the rationales of treatment is we don't want our patients to come at this stage. We want them to come right at the start when we can actually prevent the architecture of the skin being altered. Because once the architecture is altered, it's very hard to get it back to normal. Comedones are also there. Open comedones are the black comedones, and closed comedones are the white ones. And in long-standing hidradenitis, you will start seeing open comedones. And you can see closed comedones as well. They're less common, and that's because the entire follicular unit is just disrupted. So the whole hair follicle is gone, keratin starts accumulating, and that's what you see as these white spots. So let's look at a few pictures. So this is a place where you get active inflammatory nodules, and you can see these open comedones. You can see it's black. Sometimes they're called tombstone comedones as well, because it tells us it's end stage hidradenitis. It's already quite late in the treatment. As the closer view, you can see the bridging scars, which means it's bridging all those areas between hair follicles. That's what's happening here. And then all of these are completely destroyed hair follicles. It typically affects the flexures. So the typical areas are under the armpits in the inguinal area, but there are other areas you need to check as well. Between the gluteal areas, in the perianal region, under the breasts. Sometimes it happens behind the ears, and sometimes in the scalp as well. So all of these are hidden areas. Our patients usually won't volunteer and say, listen, this is what, they'll come and show you just this. We have to look specifically in the other sites. And there's always a delay in the diagnosis. They've done loads of study on it, and the average duration of delay is 7.2 years. So by the time you diagnose it, it's already too late, because 7 years, there's a lot of scarring and most of the hair follicles are gone. Considerable pain and discomfort as well. So many of our patients, it's hidden. They are embarrassed. They don't want to seek help, and it's too late. So we should actually be educating our colleagues about how to catch this early so that we can prevent this getting to the stage where they can come in later on. How do you classify it? There is the Hurley staging system, which is reasonably good. The only problem with the Hurley system is it doesn't tell you the activity of the condition. And it also doesn't let you tell you how well your treatment's working. Because if you go to stage 3, you're not going to come back to stage 1 because the scars are there. So even if you treat it, your staging is not going to improve. And that's one of the flaws of the Hurley staging system. So what is it? It divides it into 3 parts. Stage 1 is where you get the nodules and the abscesses, which I've showed you. Stage 2 is where you get recurrent abscesses and sinuses. So in the first stage, you don't get sinuses. Second stage, you get sinuses. And then the stage 3 is when it's the really late stage. And let's look at each picture. So this is stage 1. You can see a nodule with some pus in the center, and you can see a comedone as well. Stage 2, where you can see some bridging scars, again, puckered scars, some inflammatory nodules, and some comedones there as well. Again, black comedones which are open. And then this is stage 3. These are what we call rope-like scars. The scars are so thick because it's taken such a long time for the condition to evolve. So by the time you come to this stage, the architecture is completely lost. By now, you're probably looking at some form of surgical treatment to completely get rid of the problem. So we've looked at the clinical features and the pathogenesis. So now we're coming to the most important part, is how we treat it. And it's incredibly challenging. And it's challenging because people come late. So one of the most important steps is if we can teach our colleagues to send patients to us earlier, we can get treatment going quicker and therefore actually almost give curative treatment. If the architecture is lost, if that scarring and the sinuses happen, I'm afraid we can't undo it. So the first stage, when you get the inflammatory nodules, that's when we attack them as much as possible. I've divided treatment into 5 parts, and this is just something I usually tell my patients as well. I start off with general measures. I then look at topical agents, and then we have the systemics, biologics, and surgery. So in primary care, you can probably do that, but systemics, maybe some systemics in primary care, but then as you come lower down, you're probably looking at referring into secondary care. So what are the general measures? I mean, lifestyle measures are probably the most important. We've already talked about smoking and obesity. So we have to mention something about the weight in a very gentle fashion, of course. We have to tell them that if they lower their weight, it's part of their treatment. We also have to talk about smoking. Again, it's very hard to bring this up, but we have to. And the reason is, Those who smoke have a poorer prognosis and are less liable to respond to your treatment. In fact, you're 3 times more likely to be successful if you are a non-smoker than if you smoke. So if you tell our patients, listen, I'm trying to help you, and this is one way by which you can help yourself, that actually helps. I usually don't bring it up at the very first consultation. I try and do it in the second or the third, because I want to have some form of rapport and some form of confidence with my patients. You have to address both of those. Clothing is important as well. You don't want tight synthetic clothing. So the types of underwear you wear, it's probably better cotton. It's probably better if it's loose. And those are, again, things which don't occlude the hair follicles. You want something which is loose, which absorbs sweat, and which is going to be comfortable for patients as well. Again, it may not be fashionable, but that's what our patients require. Topical things, topical antiseptics and clindamycin, these are probably things I would combine with all the treatments we're going to look at in the future. Antiseptics, there was one really big study of 627 people, and they found that these are only stage 1 though. If you use antiseptics and antiseptic soaps and use a topical antibiotic, about 50% of them will respond. And I was really surprised at that figure, but it was probably mild hidradenitis, where you're removing all those gram-negative bacteria. And you can clearly see you can reverse the condition then. Topical clindamycin is quite effective. In fact, I will be quoting a study where it's almost as effective as a systemic antibiotic. So these two are well worth using with any of your patients, whatever else you use. So it's in addition to the lifestyle and the systemic agents we're going to discuss. And this is one of the landmark papers. It came about 25 years ago, where they compared oral antibiotics with topical clindamycin, and they found that both of them were more or less the same. Patients preferred the oral treatment because it's easier, but actually topical clindamycin worked just as well. In the systemics, there are 5 different classifications. You can use antibiotics, you can use anti-inflammatories, hormonal treatments, retinoids, and others. And let's look at each one of them in detail. Of the antibiotics, the British Association of Dermatologists suggests that we have to use either doxycycline or limicycline for at least 12 weeks. And the reason we use these are not because just of the bacteria, it also has anti-inflammatory action. So there are 2 components, isn't it? There's the bacterial component and the inflammatory component, and tetracyclines affects both. So that's the reason why it's probably effective there. And you're probably better off using a higher dose sometimes. So even with doxycycline, even though they start at 50, you can go all the way up to 200. And similarly with limicycline, you can double the dose of that too. So those are things by which we can optimize treatment a bit more. Rifampicin and clindamycin is probably the best antibiotic combination because it covers a very, very broad range of bacteria. The dose is 300 milligrams twice a day, and you have to give it for at least 10 to 12 weeks. Prof. Griffiths in Manchester actually did a very good series where he looked and saw that each subsequent series, actually it worked better and better. So you can actually repeat the courses till there's complete obliteration of all the bacteria. Some people have used rifampicin, moxifloxacin, and metronidazole as well. That's a relatively new antibiotic, ertapenem, and there's a series which I'm going to talk about. The only problem with that is it's an IV antibiotic and it needs inpatient care. And this was the series where they looked at this particular new antibiotic, and it should be used really as something to switch things off before you send a patient for surgery or something more severe. So what they did in the study was they had 36 patients and 35 of them showed some improvement, so dramatic results. And 71% were very satisfied or satisfied. And the quality of life also improved to a significant degree, 86%. And this is one of the patients in the study. And you can clearly see that there are sinuses, there are pustules, there was lots of leakage of fluid here when you pressed it, and that's the same there. And then after they started the treatment, after the course, these sinuses have actually healed up. All these areas of purulence have settled. But as I said, it's expensive, it needs inpatient care, so I don't think it's something we can just use easily. Anti-inflammatory, I was actually surprised to read that prednisolone is very effective for this condition. There was a series of 13 patients. Of those 13 patients whom they gave very low doses, just 10 milligrams, 11 patients responded. And I certainly have at least 2 patients whom I've got on multiple treatments. I have them on adalimumab, methotrexate, and I've added in prednisolone, and that seems to work quite well. A very, very low dose, 5 to 10 milligrams is sufficient. And you can see it works, because if you use it, for example, with adalimumab, it prevents neutralizing antibodies. Similarly, it also takes away the inflammatory cells, the T lymphocytes. Intralesional triamcinolone has also been quoted to be effective. Personally, I don't use it as much because these are very sensitive areas. The axilla, the groin, these are not places I really want to be injecting. But if you have one particular area, perhaps you can target it with steroids. Dapsone also seems to be a good choice. In fact, the BAD suggests, the British Association of Dermatologists guidelines that is, if you do not respond to an antibiotic, they actually suggest Dapsone. And this was a very good series. It came out just recently, I think within the last 3 months. And it was by the daughters of one of my colleagues, Dr. Nambi, who looked at Dapsone in hidradenitis suppurativa. So what they did is, the authors looked at 7 studies and they amalgamated all the data, and they found that 62%, so roughly about 2/3 of patients responded. The problem with these studies are, only in 3 was it used as monotherapy. So in 4, they had other drugs with it. So we don't know which one worked. But overall, I think it's a reasonable rate of response. And one of the things about Dapsone is it's able to penetrate a bit deeper into the skin. And that's perhaps the reason why it's able to go deeper into these sinuses. There are adverse effects, 25%, but they are not that great. They are nausea and anemia, and the anemia usually comes down by a couple of grams, after which it remains stable. And these are just a couple of pictures from patients who have responded to Dapsone. You can see these active inflammatory lesions, and at least 50 to 60% seems to have responded with Dapsone. Another patient who used Dapsone, and you can see that most of these are actually areas of scarring, and some of them have almost completely resolved. So Dapsone is, I guess, a useful adjunct to treatment. Hormonal treatments also seem to help. Ethinyl estradiol, norgestrol, cyproterone. The problem with hormonal studies is they are very small and they are very short duration. So we don't have good data with them. There are a couple of other hormonal treatments, finasteride and spironolactone. So we'll just look at a little bit more in detail of these 2. This is a very good article on finasteride, which I want to spend a little one slide on. And in this, they looked at 13 patients, of which 9 were males. And this was all advanced and recalcitrant treatment. So these patients had tried everything. Nothing worked. And then they put them on finasteride. But they found that most of them responded. More than 50% response rate in this group. But it took weeks to months. And sometimes they use it intermittently, and sometimes it was continuous. And the other problem with finasteride is once you stop it, the condition seems to come back. So it's something which we may need to use long term. I guess it's okay for males, but for females, I'll be a bit more careful. Spironolactone also was very impressive. A series of 20, 17 of them improved. So I'm starting to use spironolactone more and more for acne, for hair loss, and hidradenitis is again another useful condition. The dose is quite variable, 100 to 150. Sometimes you can go even up to 200. And you've got to use it for at least 3 to 6 months. Side effects, the usual side effects are some irregularity in the periods. This is only for women, by the way. And you can get some breast tenderness as well. And the bioavailability is more if you take it on after a meal, and if you take it in the evening, that's when it's probably the best. Now, retinoids, when I was a student, I was taught that retinoids are the best treatment for hidradenitis. But actually, the data isn't there. The data suggests that it's reasonably effective, but not as effective as the other agents we have. And isotretinoin can also be used. Isotretinoin is best used for younger people who are thinner. So those who are of normal weight, younger people, which looks more furuncular, those people with hidradenitis do better with isotretinoin. And that's what the BAD suggests. There's a small subsection of people with hidradenitis who may do well with isotretinoin. A couple of very interesting medications, metformin and zinc gluconate. And there are good studies here. This again is something my colleague Dr. Nambi also mentioned in a recent correspondence, and he uses it a lot. And that's metformin for the use of hidradenitis. So let's look at this study. They looked at 25 patients and they gave metformin for 6 months. And the dose was they started off at 1 gram, then they went up to 2 grams after 2 weeks, and then the top dose for another 24 weeks. And 18 of them improved. And they used 2 scores. Sartorius score is another score for severity of hidradenitis, and DLQI. And there are other ways by which you can measure it too. How many days lost was there? And that reduced from 1.5 to 0.4. So it does seem to be a useful treatment. And the BED suggests that if you have somebody with diabetes, or if you have a female who's pregnant or has polycystic ovarian syndrome, maybe consider metformin. So I think combination treatment of metformin is something I'll probably consider in the future. And again, good data. I mean, this is a 42-year-old lady who had metformin. I mean, these people had this for a very, very long time. And they added metformin almost as a last resort. And you can see pretty good results. Another lady with numerous hidradenitis lesions. You have to use it for prolonged periods of time though. Zinc is another useful thing. I mean, I always ask some of my acne patients to take zinc over the counter. It seems to have some effect on the hair follicle, the hyperkeratinization. And zinc gluconate, quite a high dose, 90 milligrams a day. I think there is something called Solvazinc, which we sometimes use. That's sometimes helpful. They gave it to 22 patients and all had some response. And this was dramatic. 8 had a complete response. So, I mean, I don't think this looks a bit too good to be true. Probably you need to combine zinc with other agents. As long as it's a dose which the patient can tolerate, usually my feeling is somewhere between 15 to 30, most patients can tolerate. 90 is a bit hard because they tend to get gastrointestinal symptoms. Going on to the biologics, adalimumab is the only biologic which has a license for hidradenitis, but infliximab and secukinumab also have some evidence in the literature. The adalimumab, there are 2 studies, Pioneer 1 and Pioneer 2. In Pioneer 1, they classified it into either placebo or weekly doses of adalimumab. In Pioneer 2, they used once a week or once every 2 weeks of adalimumab. And in Pioneer 1, there were 307 patients and the response rate was about 40%. In Pioneer 2, 327 patients, pretty good response, nearly 60%. So I guess it is one of the reasons why adalimumab is the most important biologic drug for hidradenitis at present. And these are just a couple of pictures looking at how hidradenitis nodules and inflammatory changes respond to adalimumab. Surgery is probably underused. I've started to use surgery and more now because I've realized that the architecture is quite important. So if you truly want to control the condition, you take away the inflammation, but then you look at the architecture and how you're going to rectify that. And there are various types of surgeries, mostly done by our surgical colleagues and not by us. If it's mild, just de-roof the top of the hair follicle. That's all you need to do. If it's very, very acute, again, they don't come to us. They have to go to A&E where they get incision and drainage. And if it's recurrent and in the same place and none of the systemic agents work, you're probably looking at wide excision. And there's very good literature which looks at wide excision. And if you remove all the hair follicles there, it's not going to recur there. So it is quite dramatic, but it is effective. So in those who have recurrent areas in localized regions, perhaps this is a very good option. And I certainly have referred quite a few of my patients to plastic surgery for this. Carbon dioxide laser, I found this article recently. That also seems to be quite an effective thing. It basically works like surgery, but it's a more sterile field. So here they used 34 patients, quite young again, mean age of 34, Hurley stage 2, and very, very long follow-up. Very, very interestingly, there was hardly any recurrence at the surgical site. But look at this, 25 had recurrences in other sites. So when you consider surgery or these non-medical treatments, it has to be used in conjunction with all the other medical treatments we've already discussed. You can't just use this in isolation. It'll just keep coming back at a different site. And this was the laser treatment. They used these special probes to find out where the inflammation was, and then they used carbon dioxide laser to completely remove the ducts there and the hair follicles, and pretty good healing. This is after just 10 weeks, complete healing. So in summary, the management, it's a therapeutic ladder. There's always what I tell my patients. We start off in a low ladder and then you keep climbing up. And as you climb up higher, the effects are better, but the fall is greater too. There are more side effects. I think you have to think of combination treatment. I don't think that there's a single agent for hidradenitis. You need a combination of various things. And most importantly, you have to be very, very patient. These are not things which resolve in a day or in a week. It takes months for the treatment to be effective. So my take-home points when I was researching this topic and learning more about it is, I think if you know the pathogenesis, you're going to be able to treat our patients better. And that BJD article, which came 2 months ago, I found that one of the most useful articles for me to remember how I have to treat my patients with hidradenitis. Early recognition is so important. If you do not recognize it early, if the architectural change occur, I'm afraid there's not much we can do. And we have to treat the patient according to their individual needs. Not every treatment is going to work for everyone. So try and see each person as a unique person. So I know I've told you quite a lot of information. So what I've done is I've put most of what I've learned on YouTube on this channel which I share with my father, Discover Dermatology. So I've already done a brief review of hidradenitis, looking at the hidradenitis etiology and the treatment. So it's only about 6 or 7 minutes compared to the longer talk I've given today. So do have a look. Thank you.
Thank you very much. That was a really comprehensive, very structured talk. Really useful. Should we start with questions in the room? 1 sec, we'll just wait for the microphone.
Very good talk, as usual, Dr. Yesudian. I definitely agree with your management treatments, and it's something I do for my patients. I find the combination treatment of clindamycin and rifampicin to be the most effective, even beating out adalimumab in a lot of my patients. I am a bit wary of giving them repeated courses because of the risk of pseudomembranous colitis. How regularly would you feel it's safe? Because my patients would like to stay on it, if possible, but obviously for safety reasons we can't.
Very good question. I usually try and give a break of at least a month, if possible, between episodes. In the series by Prof. Griffiths, he had given up to 5 to 6 cycles of rifampicin and clindamycin. I think it came in the BJD about 10 years ago. So as long as there's a break in treatment and your gut flora normalizes, then you could always use it again. I try to reserve it as my go-to for flares. So if they're in that chronic phase, I try all the other anti-inflammatory stuff. And then if they're saying, listen, there's quite a lot of pus here and it's painful, I give them a short course of rifampicin and clindamycin, switch it off, and then go back to my anti-inflammatories.
So you go back to something in between?
I always use combination. I don't rely on these alone. I always use the topical agents, the antiseptics, and then...
I think that's really important, isn't it?
It is, yeah. I don't think one agent, even though rifampicin and clindamycin is the best, I don't think it'll work on its own. You need the other things with it.
So another question from online was, can you combine dapsone and limacycline? What dose of dapsone do you use, and what screening blood tests do you use?
The screening blood test is usually the full blood count, USNEs and LFTs. G6PD also is useful, but it's so rare to get G6PD deficiency in Caucasians here. My dose, I usually start at 50, and then I go titrate up quite quickly to 100, 150, and 200. I warn my patients that the hemoglobin does drop by about 2 grams, and that's okay. So as long as it doesn't go beyond 2 grams and it doesn't become a single figure, I carry on. So as I look at the reticulocyte count, that's quite a useful way of monitoring it, and also the MCV. If the MCV goes beyond 105 to 110, then I start getting nervous, because that tells me that the marrow is being compromised. So if you can maintain dapsone at about 100 to 150 for about 3 months, that's the best
And the
trial.
reticulocyte count, what's your criteria?
Well, I don't have a specific one for the reticulocyte. I stop according to the MCV. I use that as my way of monitoring the marrow.
That's great. Can a recurrent abscess in the axilla in the same location be hidradenitis but no other features?
I guess it can, because sometimes it can be incredibly localized. So you can get localized hidradenitis only in one area. I have a couple of patients like that. They just have 2 or 3, one behind the ear, one in the groin. And I've always sent them to plastic. Can you just excise that area alone? But most of these people have other risk factors. They smoke, they are slightly higher in BMI. And plastics always say, oh, sort that out, and then I'll do this. So it's always a tug of war with them. Yeah.
Of course, there's a few similar ones as well, and sometimes there's the follicular occlusion triad.
Exactly.
And if they're on isotretinoin for acne, suddenly they get a recurrent area.
Exactly.
So that's quite interesting. A definition question: what's the difference between abscess and nodule in hidradenitis?
I guess abscess is the more softer version, where it's about to burst, and nodule is pure inflammation, so you get more of the redness. It's very subjective. I don't think you can truly differentiate between the two.
Spironolactone, is that given to male patients? I think you've already answered that. Just for females, what would we need to monitor renal function for spironolactone, and how long would they stay on this for?
There's very good data from America that if you're young, if you're a young person, you usually don't need to monitor spironolactone. You can do a baseline blood just to make sure that everything is fine. But generally, I reserve my monitoring for above the age of 40 to 50. If you have some renal dysfunction, if you're on other medications like diuretics or any antihypertensives, then I start monitoring.
It's usually the potassium, if they're eating lots of bananas. So just
ACE inhibitors.
For prednisolone add-on, how long do you normally use the prednisolone for?
Well, I'm afraid I have to use it indefinitely. I have 2 patients, and they are both on it for months. So I think it's very hard. This study, they used it for at least 6 months. But in clinical practice, I think once you start it off, it's quite hard to remove prednisolone.
Do you find that they gain weight? And that
Not with 10 milligrams. Both my patients haven't had a problem, but of course it's anecdotal evidence.
And you really give them bone protection and everything.
Exactly, yes, you do. Most of them are young, so they don't need too much of bone protection. Yeah.
So is it selectively, do you use them in a particular age group with the prednisolone?
Well, both my patients are on a biologic and methotrexate. Right. So I've added prednisolone as an add-on, both of them. They're both in their 30s.
There's quite a few questions coming in. It's clearly a popular topic. How do you differentiate folliculitis, acne, and hidradenitis?
Again, it's very, very subjective. With the folliculitis, again, you're looking at that pointing and the superficial nature. As a dermatologist, we always have to palpate the skin as well. We just can't see it. So when you feel it, and it feels quite deep in the dermis, not superficial like a pustule, only on the surface, then you know it's pretty deep. That becomes a nodule. And folliculitis tends to keep shifting. It won't just be in one place. It'll keep shifting in all the hair follicles. Whilst with the hidradenitis, these nodules keep occurring at the same site again and again. So those are the easier way of differentiating.
How would you treat a patient who has flare-ups mainly during her periods?
Again, difficult, isn't it? I think knowing the organism and trying to target the organism is useful. And then doing all the other things, the lifestyle things, the antibiotics, the anti-inflammatories, finding the right anti-inflammatory and antibiotic for that person is probably going to be the best. Rather than concentrate on the periods, I'd rather they have it all the time, because that way you can suppress it all the time. Just to use it only during the periods doesn't work, because it's a long-term treatment.
Now, I was interested in the data on the bacteria, because that was actually not something I'd been realized actually. So you'd think that things like metronidazole and stuff would work quite well, but we
It
don't
probably
use it.
will be. The problem with metronidazole is it's not easily tolerated,
Okay.
and using it for prolonged periods again is not the best option. But there are few reports of clindamycin with moxifloxacin and metronidazole being used.
Okay.
So I guess more and more we need to look at the gram-negative from outside with antiseptics, and then use inside as anti-inflammatories, antibiotics.
That's a good analysis. And Staph aureus, so you don't feel it plays...
well, from the literature, not so at all, not Staph aureus. The other staph is, but not Staph aureus.
And so taking swabs, what's the role of that? Nasal swabs, like other areas?
I don't think the other swabs are useful, but taking swabs from the area of hidradenitis to try and find if any of these organisms are there, and then look at the sensitivity may be useful. Okay. But it's not the bacteria alone which is the problem. That's the issue, isn't it? You need to look at the inflammation as well.
So you mentioned that changes in the commensals implicated in pathogenesis. Any evidence of treatment to try to restore the skin microbiome to help hidradenitis?
I don't think there's any study on that yet. All those data which I gave you just came 2 months ago. So perhaps companies will be starting to look at that and targeting those bacteria more specifically. But the problem with the bacteria is, are they primary or are they secondary? Is it the hair follicle which is getting blocked first and then the bacteria coming, or the other way around? We still don't know.
I just had a couple of questions. Otherwise, in terms of imaging, do you feel like there's a lot of role in like trying to sort of, because some people have obviously Crohn's disease and other conditions as well, and sort of working out how much is. Do you think you can do it all clinically, or is there?
No, I don't think so. I think imaging probably goes beyond our remit. If you are suspecting something like Crohn's, you probably need to do a biopsy. Imaging is probably before they go for plastic surgery. The surgeon probably needs to know how deep they are, and for that imaging would be helpful. But for us as dermatologists, I don't think imaging is going to help us in our management.
And you mentioned the word cure to some of the, do you use that in your consultations if it's early on?
Not for hidradenitis, no. I try and tell them, listen, I'm going to try my best to control it. Probably shouldn't have used that word cure. I tell them I'll try and control it as much as possible. But from the evidence, if you catch it really early and you prevent the sinuses forming, I get theoretically it is possible to cure it. It's like acne, isn't it?
So if you think if you can, and the way to treat that would be using anti-inflammatories for a set period and then using a maintenance treatment.
Yes, you probably use it like acne treatment. You try and go really hard on it very early, completely get rid of all the inflammation, open up the hair follicles as much as you can, and then hope for the best.
Good. Metformin, what dose do you tend to use?
Well, I personally haven't used it. As I said, one of my colleagues mentioned this, and I came across it in my literature review as well. But I probably will be starting to use it. And the dosage they mentioned is 500 for the first week, then 1,000, and then they go up to 2,000. So I guess that can be increased very quickly, and then kept on it. I mean, I've read so much about metformin. I've read all these anti-aging books, and metformin seems to be a wonderful drug. So I don't see why we can't use it in dermatology.
I did some research into that as well, and I've used metformin, but I haven't had the benefits. I wondered if it was a sort of people who have like pre-diabetic, or if there's some other, if there's something to sort of triage who you use it for. But the ones I'd used it, I didn't see much.
I think probably it's an additive, and the BAD suggests for, as you said, pre-diabetics or diabetics, or PCOS in women.
Another question?
That's a bright Hurley. It's a big component of metformin for the hidradenitis. And I started using it as a combined treatment with antibacterial for my patients as well. He's even recommended it for patients who are not diabetic yet, and I'm starting to try it in some of my younger age groups to hopefully, prevent progression to the more severe stages. So let's wait and see.
It does seem to be a very good drug, actually. It's got so many anti-aging properties, so many good metabolic changes. Even if you're pre-diabetic, it may work, as you said. So I think it's probably I've missed a trick. I probably should have used it a bit more.
Someone's asking, why spironolactone only for females?
Well, all the studies have been done only in females, and I think its anti-androgen effect seems to be more powerful in females than males.
Any suggestions of antiseptics apart from Dermal 500 and Hibisco?
it's got to be one of the chlorhexidines. That's the only thing we have easy access in benzalkonium chloride. I mean, those are the ones which are effective, what we have in the UK.
Yeah. And the clindamycin preparation that you prefer, is it
It's the 1%, yeah.
Okay.
Clindamycin solution, Dalicin or
Dalicin,
Cindaclin,
yeah. Great. Any other questions? Otherwise, I think we'll end it there. Thank you very much. That's fabulous. Thanks a lot.
Thanks a lot.